Sollis. Better insights for better outcomes. This session was recorded live at our Advances in Population Health Management workshop in London, November 2018.
Welcome, Alex, and please, the floor is yours.
Thanks. So as sort of Nigel said, I'll spend this first sort of 5 minutes talking a little bit about where the business came from and where we are now, and then spend the sort of second half talking about how we can, or how we are going to be working with Sollis to improve the capability of what we can do. A lot of people today have touched on the idea that we have to move from a reactive-based model to one that's proactive, and to one that takes into account social care. For me, it sort of started, as Nigel said, when my grandfather was diagnosed with dementia. I was looking at what was available for him, but also for the family around him. Something that could help him, but give the family reassurance that he was okay. I mean, early on I came across this thing called telecare, which was sort of sometimes combined with telehealth. And sort of looking into it, and you had a red panic button that you could press, and that would create a phone call to a monitoring centre, and then at some point they would ring the family up to say, oh, your dad's fallen over. And for me it was totally reactive. There was no way that the family around him could actually proactively see that dad is okay, or that dad is showing a little bit of sort of strange behaviour, I might want to intervene. Or to know that the carers turned up when they said they were going to turn up, so actually I can go into my hour-long meeting with no signal coverage, knowing that the carer's there looking after dad and not, is he still laying in bed and hadn't had any breakfast. So I started developing a range called Memo, and it was built around those three principles of prolonging independence for the individual, providing the reassurance for their family and carers, but also the actionable data and insight to social services and healthcare providers, which I felt was lacking. And sort of, I'll come on to how we can then work with Sollis to do that. But for me, in terms of that actionable insight, local authorities didn't have any way of really knowing what was going on in the home. And a lot of what we're talking about today is looking at the data from primary and secondary care. But in my mind, often once somebody's in primary or secondary care, that's already too late. We should be looking at how we can intervene while the individual's still in their own home to prolong how long they can stay in their own home. And part of that picture is working out what's going on in that home, building up what behaviour is normal, but also then being able to analyse changes in behaviour that might flag that something's up. So for us, it could be as simple as learning when they always tend to make a cup of tea in the morning, and if they don't, that could be the first indicator that something is actually wrong. Or analysing their behavioural pattern, when they tend to get up, when they tend to go to bed. For most people, it's pretty common. And we can then look at changes and how that's starting to change, which could be a precursor of dementia, or multiple bathroom visits being a precursor for urinary tract infections. But one of the things that's missing with what we're doing is being able to validate that information. There's two things. There's firstly being able to identify the individuals that should have this before they're actually ill, which for local authorities at the moment they struggle with, because you want us to spend more money to give this to someone that currently wouldn't be required to have a red panic button. And our argument is yes, but actually if you give somebody a red panic button after they've already fallen, you're already too late. And the second way is being able to look at the impact that proactive care can actually have. So when somebody presses their panic button, or they have a fall, did they go into hospital? How long did they stay in hospital for? And why was it they were in hospital? So then we can learn behaviour, spot what that behaviour has led to, so that when we see that same behaviour with that same kind of individual, with the same background, same conditions, we can then start predicting what may happen so we can intervene, but on the back of an evidence-based. So that's probably an introduction for coming to how we are looking to work with Sollis. Graham, do you want to...
Yeah, so, I mean, this is the slide that's basically about us, which I don't think I want to go through, because many of the people have heard so much about what we do anyway. But the key thing here is identifying the individuals who might be helped by this sort of technology. And in particular, some of the things that may help in this area are issues to do with patient activation, frailty, and some of the NHS dementia-related indicators that the NHS England promoted 2 or 3 years ago. So it's not your classic risk of hospital admission score, but it's much more to do with how able people feel in their own home.
Well, I sort of went into the first bit is identifying those individuals. With local authorities at the moment, the big struggle is getting them to spend money now on something that they don't see as a problem right now, in order to be able to save money further down the line. And the other challenge for us is getting adult social care to spend money when in their mind, well, you want us to spend money so an individual doesn't go into hospital. Well, that's not our budget. That's the NHS that's going to save money if we stop them from going to hospital. How do we realise this? And I think the landscape is changing, and it's going to help bring the two together. But for us, it's having that evidence base that we can actually start to say, look, if you spend the money here, you can stop an individual going into hospital. But more than that, one of the main activities for adult social care is providing domiciliary care. At the moment, you put a domiciliary care package in, but it's very hard to work out when that domiciliary care package should be removed or how much domiciliary care should be put in the first place. Whereas actually, if we have a sensor-based system where we can look at activity around the home, we can see if somebody's getting in and out of bed, if the carer's turned up, or actually if they're getting out of bed without the carer having to be there anyway, we can then start to work out what is the optimum amount of care for an individual. But also to tackle one problem, which is you put domiciliary care in, an individual becomes more capable, and they get up sort of back to roughly where they were before they had the illness that required them to have domiciliary care. But then if the domiciliary care stays, the individual then starts to become dependent on the domiciliary carers, and then their capability starts to reduce again. So one of the things we want to be able to do is look at what is the optimum amount of domiciliary care, so we can put that package in place to ensure that you're not making those individuals become reliant on that care. And partly it's the information that we can get from Sollis as to identifying those individuals and looking at what is the impact of this behaviour for the individual. And I think there's a few more.
So one of the things here is it's all very well to do the case finding, to capture the individuals who may be helped in this way, to maybe target exactly what other devices they need in the home, whether it's full sensors, whether it's really interested in heating and lighting and things like that, all the things that Alex has been talking about. That takes you so far, but actually the really gold standard is to capture the data back from these devices, not for the alerts, but to track long-term trends, to see if actually it is working. So here, this is a faked graph, by the way. This is not real data, I have to say that. But this is the point at which the activity in the healthcare sector starts to fall, because they were getting slightly better support because they've got more reactive technology in the home. And this is the sort of thing whereby the first port of call might be the device, when it notices something that's a little odd, it might ring a neighbour, or a relative or a carer, or there might be a tree of people to call before emergency services are alerted. That sort of flexibility can be built into the tools, so it can be really about that person's network of support, rather than, okay, that means now we ring so-and-so.
Yeah, and for us it's alerting the family members and carers via an app. With a sort of triaging system where if they don't respond within a certain amount of time, it gets escalated, but also having a dashboard that local authorities can use to look at individuals both at an individual level but also at a population level, and that's where we want to start building in more and more tools into that. Fundamentally, our platform has been designed to appeal to a consumer market. Because with these sort of technologies, local authorities at the moment tend to fund this, but increasingly that's probably going to there would be a decrease in the amount that they can fund. So what we need to have is a platform that people don't mind having in their own home, something that feels like a consumer device, but is on the back of regulation and standards that mean it can operate in the same market that current telecare and telehealth devices do.
Excellent, thank you. Thank you, Alex.
For more information and insights, visit our website sollis.co.uk.